So the format for today's event is intended to promote an interactive conversation. To join the conversation, you may raise your hands or enter your thoughts and questions into the chat. For those of you who are not familiar with MHCC, MHCC is an independent state regulatory agency that supports advanced care delivery and practice transformation. We collaborate with payers and providers to transition to quality-aligned, value-based care and to harness the potential of data in facilitating meaningful change. Next slide, please. So this slide outlines the important information about CME credits and disclosures. Following the event, you'll receive an email that contains a link to a questionnaire. The questionnaire requests feedback on the forum and an application for CME or continuing education credit. We appreciate your feedback, even if you're not applying for CMU or CEU credit. The planners and reviewers for this activity have reported no relevant financial relationships to disclose. Next slide, please. So today's learning objectives include recognize areas where patient care can be improved through data analysis and feedback, set goals with clear measurable targets for improvement, implement changes by testing new approaches and interventions to address identified issues, and to regularly track progress and adjust as needed to optimize outcomes. Next slide, please. So today we're going to start off with an overview of select MHCC practice transformation activities. Next, 3 speakers will discuss their perspectives on our main topic. We'll hear from Molly Daughtry, today's subject matter expert, and our other presenters will be offering us practice perspectives. And they include Dr. Brodeen from Franklin Square Family Health Center and Dr. Farazbi from Adventist Healthcare, who's the medical director of the Cancer Service Line. Next slide, please. So I'm going to now provide a brief overview of some select MHCC practice transformation initiatives. These initiatives are designed to support the Maryland model goals by readying practices to participate in value-based care models. Continuous quality improvement is a key part of that transformation. Next slide, please. So advancing practice transformation has been an MHCC's strategic priority for more than a decade. The first practice transformation program was the Maryland Multi-Payer PCMH program, which ran from 2011 through 2016. The MHCC then partnered with MedChi, the University of Maryland School of Medicine, and the New Jersey Innovation Institute to complete activities in Maryland as part of the Transforming Clinical Practice Initiative from 2015 to 2019. This was a federal initiative that included over 124,000 clinicians. The MHCC has also contributed to planning and development for the Maryland Primary Care Program since its inception in 2017. Next slide, please. So in June of 2021, MedChi CTO was competitively awarded a grant to complete practice transformation activities. The program is designed to help practices collect, analyze, and utilize patient data in a way that enhances both efficiency and patient care. With tailored coaching, workflow redesign, and support, the APT program ensures practices have the knowledge needed to drive meaningful change. So approximately 77 practices have completed program milestones to date. So we are still accepting applications for this program. So please reach out to me if you're interested in staying ahead of the ever-evolving landscape of healthcare and leveraging patient data effectively to improve care delivery, optimize practice operations, and achieve better patient outcomes. Next slide, please. So the MHCC convenes peer learning network events like this one in collaboration with local and national healthcare leaders on topics such as health equity, advanced care delivery, and practice transformation. More information about the network learning events are available at our website on the link listed on this slide. Next slide, please. So 2 recent events included a mental health collaborative care summit and exploring CRISP data. Next slide, please. So we're very excited to announce that we're planning to add a new initiative in 2025. We plan to offer 10 to 30-minute pre-recorded on-demand sessions to support practice transformation in advanced care delivery. So please let me know if there are any topics that are of particular interest of you that you would that you think should be included in this initiative. So next slide, please. So I'm going to now turn the presentation over to our subject matter expert, Molly Daughtry of MedStar.
Thank you so much, Melanie. I'm happy to be here today. Again, my name is Molly Daughtry. I'm the Vice President with MedStar's Care Transformation Organization. I also oversee MedStar's operation of their MD-PCP program, or the Maryland Primary Care Program, which many of you may have heard of. And I do that in collaboration with my partner, Dr. Joseph Brodeen. I'm going to ask him to introduce himself. Next slide, please.
Thanks so much, Molly. Good morning, everyone. Good afternoon, everyone. I'm Dr. Brodeen, and I work as a family medicine physician practicing full scope primary care in Northeast Baltimore, and also, as Molly mentioned, as her partner, overseeing the MedStar's involvement in the Maryland Primary Care Program as the medical director for the CTO. Thanks, Molly.
Thank you. Next slide. Okay, so today we're going to be talking about continuous quality improvement. I'm really excited to present on this topic for you. It is a central part of the work that we do in the MD-PCP program, always working to improve the quality of care of our patients and their performance for our practices. Next slide, please. So I always think it's really helpful to make sure that we really understand what it is that we're talking about. So I've included a couple of definitions here about continuous quality improvement. So continuous quality improvement is a progressive, incremental improvement of processes, safety, and patient care. The goal of CQI may include improvement of operations, outcomes, system processes, improved work environment, or regulatory compliance. Projects should be targeted at specific, quantifiable patient care or operational outcomes. And projects should be designed in line with institutional interests, values, and key stakeholders. Next slide. So when we talk about continuous quality improvement, one of the very first places where we want to start is identifying exactly what type of improvements we want to make and need to make. And sometimes we're not exactly sure and we don't know how to figure that out. So I want to talk about a few different manners in which you can determine what are the most important things for your practice to focus on. So you can get a lot of information from patient feedback. I know a lot of our patients these days are getting surveys left and right, but these surveys provide you with valuable information about your patient's perspective of your practice operations, what's important to them, some changes they might like to see, and recommendations that they have. You can consider conducting patient and family advisory council meetings. These are regularly scheduled meetings. They should happen a minimum of annually, where you invite your patients and their caregivers to a meeting and you ask them for input. You may come with some specific tailored questions that you'd like for them to provide feedback on, but this is often an opportunity to develop relationships or build relationships and really gain some trust from your patients so that they will give you good feedback on some areas of improvement your practice might have. You might want to consider a classic comment box in your waiting room. Leave some slips of paper and a pen for folks to just jot down anonymous comments that they can put in your comment box. And then most of us these days have an electronic patient portal. Consider sending messages through your patient portal to gather information from your patients. Next slide, please. You might have some clinical quality data. So you might just determine that you have some areas of improvement related to clinical quality measures. You've done some analysis and you're finding out that you have patients who you have area of improvement in, for example, A1C might be an area where many of your patients could have improvement. And you would learn that by analyzing your data on your quality metrics. Perhaps you have some information about your appointment waiting room times. Maybe your patients had provided you feedback that your waiting room times are too long. And you might understand data about that to find out if there is an opportunity somewhere for you to make improvements. Perhaps you have appointment data that you can look at. Is it taking too long for patients to get an appointment scheduled? Are your no-show rates very high? Are your patients canceling and not rescheduling? These are all places where you might determine whether or not your practice has an opportunity to make some improvement. Next slide. Perhaps you have a revenue cycle management issue going on. Perhaps patients aren't getting registered properly, and your front desk staff aren't necessarily gathering all of the pertinent insurance information. And you know that because you're getting claims denials. So you've done a little bit of analysis on your claims denials, and you're determining, aha, it seems as though we have frequently times when our patient insurance information is entered incorrectly. But understanding all of the steps about your revenue cycle management can help you understand whether or not certain points along the way are getting in the way of you all collecting on your payments. Next slide. Perhaps your practice is involved in a value-based contract, and your value-based contract explicitly states that what their expectations are for your performance. And if you're analyzing your data and you're realizing that you are not meeting the performance metrics that are specified in your value-based contracts, you know that that's likely an area of improvement that you want to focus on. Centers for Medicaid and Medicare publish benchmarks for performance. You can take a look at those benchmarks and compare them against your own to determine whether or not you are meeting or exceeding national benchmarks. And our managed care organizations also publish benchmarks. Perhaps you want to take a look at those to determine whether or not you have improvement areas for certain specific payers, Medicaid or some other type of payer. Next slide. When you decide what you want to work on, you want to make sure that these initiatives are specific to your practice. So you have determined that these are important to you. We want to make sure they have a clinical focus. Our goal is always to improve the patient care. Oftentimes there's a financial incentive to making some improvements in your practice. Operational streamlining can take place for some operational efficiencies. And programmatically, the structure of your program and adhering to rules and regulations, those things are important as well. Next slide. So once you've identified certain different areas where improvements might be an opportunity, you might want to plot those opportunities down on a priority grid where you are determining what are the most important things that I want to focus on now. And then perhaps you can also find an opportunity for some sort of low-hanging fruit as well. You might see that, hey, we have opportunities here to make some improvements, and these are easy opportunities, to target. So we're going to do a little of both, you may decide. But plotting them out on a grid like this will really help you visualize where your best opportunities lie. Next slide. Once you determine what you'd like to do, it's always good to put down an actual plan. So you want to understand first and foremost, what is your goal? What are you trying to achieve? It's a good idea to invite your key stakeholders to your initial planning meeting. So perhaps you have staff at your practice that are subject matter experts, say on like in patient enrollment or registration. As an example, you might want to invite somebody like that to your meeting because you want to have buy-in. Plus, you understand that they do have an expertise about the operations of the practice that can really play in well to your action planning. So you want to have your first meeting where you've gathered your stakeholders and you want to lay out the vision and the goals for this activity, this improvement activity. You also want to establish measures by which you determine whether or not you're making progress, right? It's always good to have a clear understanding of whether or not you are in fact making progress towards your goal. You really only know that if you've established benchmarks and measurements along the way. Next slide. I've included here just a very basic plan that you could consider using. It highlights the goal. You have a place to put all of the actions that are required to get to that goal, the responsible person for each individual action, the resources that individual is going to need in order to conduct their actions and achieve their goals, a due date for when you'd like to see certain steps along the way take place, and then some status updates, a place for status updates. Your staff can go in, or you can go in and provide written status updates. You can schedule meetings in these blocks, and then any comments that helps you understand sort of what's going on along the way. And then you want to come back and meet regularly to discuss this plan, to walk through it, and to assess the progress that you're making. Next slide. So that was sort of what I was just, continuous evaluation was just what I was talking about. You want to make sure that you're coming back regularly at regular scheduled frequency to take a look at your progress, to do some assessment of whether or not your actions are working, and to make some changes if needed so that you can improve, you can make better improvements along the way. And then this is a regular ongoing cycle. So you want to be conducting these activities at a regular frequency, ongoing throughout the process improvement project. So you want to meet, you want to evaluate your progress, you want to make any changes or tweaks that you need to, and then you want to give those tweaks a chance to work, and then come back and reassess again. It's an ongoing iterative process. Next slide. Okay, now I'm going to turn it over to my colleague, Dr. Joe Brodeen, who is going to talk about a real life example that the Care Transformation Organization and MedStar worked on together related to continuous quality improvement. Go ahead, Dr. Brodeen.
Thank you so much, Molly, and thank you for such a good and thorough overview of the process that we know is well described in the literature, and certainly is the process that we followed as we were implementing this across our system. And I can also speak from the perspective of our very specific clinic where we saw this take place. So next slide, please. Okay, so just as a little bit of background, I know that we introduced ourselves earlier, but just to remind, Molly and I oversee the Care Transformation Organization, which is a unit that at MedStar that facilitates our participation in the Maryland Primary Care Program, which involves a lot of good care management for Medicare B patients. The MedStar CTO has about, at any given moment, usually around 45,000 Medicare B beneficiaries attributed to us. It's a good example of one of the ways that the state has embraced a value-based care model. And as is typical with such models, incentives for good performance is offered, and performance is evaluated in terms of cost by trying to reduce the cost of patients and care, and also trying to improve the quality of their care. And a lot of the funding that we get from the program supports efforts to address unmet care opportunities. Next slide. So we'll keep that in mind as we talk about additional background. One of the ways that our program evaluates our performance is how well we perform as a system, and really at the individual clinic level in terms of improving certain patient quality measures. And one of those, as I'm sure most of the folks on this call have similar in their practice environment, focuses on good high blood pressure control. So this is a bit challenging, and if you can advance the mouse a little bit more, this is a bit challenging because good blood pressure control is definitely clinically important. And the CMS measure definition is a little bit tricky because it's looking for whether or not the person has a blood pressure of less than 140 over less than 90 to meet the measure. But what's tricky about it is that you can have a patient who's got a good blood pressure throughout the year, but their last documented reading at the end of the year can negate all of those other good blood pressures in terms of the measure, because they will show up at that point as failing the measure. So again, if someone had a blood pressure of like 120/80 for most of the year, but on the last day of December, they have a blood pressure that's documented as 141/80. All of a sudden, they're failing that measure. And this is not really an ideal measure necessarily, as I'm sure other folks on the call might agree, because it doesn't really get at the fact that who really needs care management versus who is maybe just experiencing a variance in their blood pressure. Next slide. Yeah, next slide. And keep going. Thank you. So on our CTO, we have this quality team. The quality team is a kind of a special group of folks that stand out apart from all of our other care managers because they are medical assistants, including a supervisor, who are very focused on specifically reaching patients who have unmet quality measures. This would include things like blood pressure, also diabetes. Also, we try to help them get screened for cancers like breast cancer and colorectal cancer. And they do their work by making phone calls. For the last 3.5 years, they've been making manual phone calls, which is 100-year-old technology. I love the phone. It's a good thing, but they spend a lot of time on the phone. They can only reach a certain number of patients each day to try and work with them to make sure that their blood pressure is well controlled and that they're taking their medicine and figuring out who might need to be escalated to care management or not. And so that quality team typically engages at the end of the calendar year in a blood pressure sprint, because we're trying to really get a good sense of our performance, our own performance, and understand how we're doing in terms of how well we're controlling blood pressure. And what we really want to understand is if we have a measure that's telling us whether someone's last blood pressure is, under or over this threshold, are we really understanding who is generally well controlled but just had a slight elevation in their very last blood pressure? Or do we know who's typically not controlled and therefore needs more care management? And that's what we're really aiming to do here. Most patients who failed the measure, we found, were within about 10 to 15 millimeters of mercury above the threshold, and tended to be well controlled for much of the year. Next slide. So the last terminology to introduce here before talking about our actual intervention is this technology that maybe some on the call have heard of. It's called Twistle. It's a communication software platform that's offered through the parent company Health Catalyst. And this product is basically, I think for want of a better term, like a chatbot, except as the client, you can design it. So we were able to work with this group to kind of design our own algorithmic-based chatbots and use it to engage with patients. And we wanted to try and use this to reach out to patients during our end-of-year assessment and see if we could figure out who actually has good blood pressure control versus who's going to really need care management, moving forward. So next slide. So when we talk about our methodology for this quality improvement process, a lot of it's really well represented in the slides that Molly shared. Next slide. We started with a meeting with stakeholders. We talked specifically with their primary care leaders, and we really gauged their interest in the need for this. And we were really pleased and thankful that our primary care leaders at MedStar were very engaged and thought that this would be something that was relatively novel for MedStar in terms of an approach for patient population outreach to see if we could quickly tease out who needed to be supported with maybe just some basic education or just some follow-up that could be automated versus who needed to be triaged to a higher level of care. And we also wanted to make sure that as we were doing this outreach, our primary care leaders were giving us a good sense of how we could manage the responses from patients. We then also partnered with the digital health group at MedStar, who helped us to kind of build and develop this chatbot. and we were able to test the outreach process with some test patients and figure out how this could work from an operational standpoint. And then, of course, we had our care management team that included the quality team I mentioned, where we were able to get from them how they would imagine interacting with this process. And we were really pleased to hear from them that they were excited about this because, again, they're making manual phone calls every day. They're trying to call as many folks as they can, but they can only get to, a dozen and a half patients a day or so. And this chatbot meant that we were going to be able to reach out to, logarithmically more, a higher number of patients than that. So let's go to the next slide. Part of our um, uh, part of our automated outreach process meant developing a clinical and operational protocol. And as we were kind of getting into this space where we had never been before, we were thinking about using technology as the first point of encounter with the patient, when knowing that we had human beings on the back end that could respond to the exceptional cases where someone needed kind of an urgent assistance. And so the aim of this, of course, was to really improve the accuracy of our measured performance and understand where we needed to support patients who had moderately high blood pressure, but we also needed to be able to understand how we could efficiently deal with patients who had high risk blood pressure and have a really good clinical response for them. Next slide. Next slide. There we go. So if you're conceptualizing the model of kind of how this looked, you would imagine that we have an EMR here at MedStar, here at our clinic, that is owned by Oracle. And we tapped into that EMR to load data into an analytics cloud. So there's basically a data analytics engine that is also owned by Oracle that's sort of absorbing this information on the back end and is able to sort of generate lists of patients. So we know who our patients are that are not meeting this measure. And this analytics piece was really important to streamline our process. That list could then be generated and loaded into the Twistle platform, which again is this like chat bot that we were working with this company Twistle to build. And then that could be sent out by text message to patients who would then be asked about their home blood pressure readings and could report on their home blood pressure readings, because obviously we've captured all their last blood pressure readings at a clinic visit, but we know that since that time they've maybe taken different doses of medicine because their doctor adjusted their dose, or perhaps they were just a few points above because of white coat hypertension, or because maybe they've improved their diet, or whatever it is. We think that there's going to be some difference in terms of the folks that respond. But it's important to note that we only sent this message to people who we knew were not meeting the measure. So in other words, these were all people whose last recorded blood pressure was considered hypertensive. Next slide. For the folks on the call, if you wanted to get a sense quickly of the algorithm here, you could see that when we program the chatbot, it would outreach to the patient and ask them if they had a home blood pressure available. If they did not, we would offer them a blood pressure cuff, education, and the possibility of care management when appropriate. If they did have a home blood pressure available, we would ask them to write that into the chatbot and send it back to us. If the chatbot recognized it as a normal value, which would be less than 140 over less than 90, according to the way we had set it up, then it would encourage them to continue taking good care of their blood pressure control and follow up with their doctor as routinely scheduled. But if they had an abnormal blood pressure, then we would offer support to those individuals with moderately elevated blood pressure. And for those who had significantly elevated blood pressure, we would have a very specific kind of active follow-up. Next slide. If you were to have received a link in your phone, it might look like this image that you're seeing in the upper left-hand corner, where it's basically just saying, hey, you have a message from MedStar Health, click on this link, and the link would then take you Next, you can advance a little bit to like a web page that you would confirm your identity by signing in with your date of birth, and it would again pose those questions that I was just describing in that preceding algorithm, and give patients an opportunity, if they have it available, to upload their home blood pressures, and that way we're checking in with them to see if there's a difference with their current blood pressure now compared to their last known recorded blood pressure, which was elevated previously. Next slide. So when it came to implementation, again, we kind of followed the playbook that Molly had outlined. Next slide. We made sure that we had a goal kind of defined so that we could measure how we would reach these 11,000 patients whose last known blood pressure was out of range. And we wanted to make sure that we understood how to manage those patients, patient-reported blood pressures. Next slide. We made sure that we had consensus with primary care leaders for blood pressure response. For normal blood pressures, we would upload that into the EMR and notify the PCP and offer a supportive and encouraging statement to the patient. But for the elevated non-emergency blood pressures, we would offer education follow-up and care management as appropriate, as well as engaging with the PCP. For emergency blood pressures, we would immediately navigate the patient for same-day care with their PCP, and if their PCP was not available, we'd find an alternate PCP at the practice, and if that wasn't available, we would refer them to one of our MedStar urgent care locations. Next slide. We started this outreach with waves of 500 patients a day, just because we wanted to make sure that we were watching closely in a continuous process to make sure that the chatbot wasn't failing in any way. And we stayed in daily contact with our care management team and made sure that we had all the resources needed to ensure timely clinical follow-up. And then we were checking in weekly with our clinic leaders to make sure that they were kept apprised of our progress. Next slide. So here were our results. Next slide. We deployed this text message outreach over a period of about 20 days last year. There were 10 total waves of text messages, about 500 to 2,000 patients per wave, and all told, about 9,200 patients got a link. Next slide. If you were to look in the dashboard, this is what you would see within the Twistle software. You would see that someone might have written back and said, well, now my blood pressure is 119/86. And so our care management team would capture that, and we would see that with this little green thumbs up on the dashboard. Next slide. A thumbs down that's kind of like salmon colored is showing that this patient reported back, and still their blood pressure was kind of unchanged from the last time it was measured. Even at home, it was 147/74. Next slide. Very importantly, there were folks who wrote us in back with their blood pressures, and this individual said that they were 223/88. And so they have this bright red thumbs down, and this would catch the eye of our care management team, so we could immediately work with those folks and get them plugged in same day with the with their PCP, or barring that, another doctor at their clinic, or barring that, urgent care. Next slide. The total results are shown here. Again, about 9,200 people ultimately received a link. We texted more than that, but a lot of phone numbers failed. Probably about another 1,000 phone numbers failed, which is an interesting piece of data. The important thing here is that about 2,600 patients clicked the link and actually fully submitted responses. So it was nearly 30% response rate, which was very pleasing to us. Out of those individuals, the majority, which was about 1,500, did not have a recent home blood pressure, so they had nothing to share with us. So we just encouraged them to make a follow-up with their PCP. Nearly 800 were categorized as now meeting the measure of performance, where they previously had been failing it because their blood pressures were actually within limit when they were testing it at home, perhaps again because they had started taking perhaps a different dose of medication at the direction of their doctor, or perhaps they were observing better dietary precaution, or perhaps hypertension, white coat hypertension syndrome was no longer in effect for them. We know from data that people's blood pressure readings at home do tend to be anywhere between 5 and 10 millimeters mercury lower than in clinic often. About 382 folks had unchanged hypertension. And I think one of the more striking things that we had planned on, but didn't know exactly how many this would be, is about 40 people had what we considered a significantly elevated hypertension of a systolic greater than 180 and or a diastolic greater than 120. Next slide. You can see a little screen capture here of a person with such a value. She had a value of 226 over 139. And you can see from the note here from the staff that this person, after getting the text, actually went to her primary care doctor's office. They made a same-day appointment, which I know is really hard for all of us in primary care because of access issues, but she was able to get in, which was great. And she had actually run out of her blood pressure medications. Didn't have any obvious symptoms, but was really glad that the text kind of inspired her to take her blood pressure and get her into care. So next slide. Just as a quick take-home point, this automated outreach mechanism really was an effective way to communicate with patients. And as I mentioned, from a quality improvement standpoint, not only did it improve the quality that was measured here in terms of how we measure our care, but I think also we now knew that there was this group of patients that didn't really need precious care management resources. They were pretty much fine. And our quality team had a force multiplier that helped them seize onto those patients who needed immediate care. And now we also know who are the folks that have just sort of persistently high blood pressure that might benefit from long-term care management. So we really enjoyed this exercise because as a quality improvement technique, it kind of got us to where we needed to go with how we're using our resources. Next slide. I'll just comment briefly that this really led us down a path of trying to improve with other quality measures over this past year. We've done this with a couple other conditions like blood sugar and cancer screening. And as a matter of fact, as of today, as of this morning, our team is actually pursuing this year's blood pressure outreach. As of 10 a.m. this morning, we reached out to our first wave of 1,000 patients. So it's definitely got us on a good path of learning how to engage with patients digitally and use use a technology as a way of advancing our quality improvement process. So I'll stop there and say thanks for everyone's attention and turn it over to Molly for any additional thoughts before we turn it over to Dr. Frosby.
Thank you so much, Dr. Brodeen. I really appreciate the way you always walk through these excellent slides and talk about the process that we went through. And just to kind of wrap it up, so the CTO in collaboration with MedStar Medical Group determined that we have a value-based contract, right, that has some quality metrics that are associated with it. We determined through analysis of our EHR data that we had area of improvement with those quality metrics. We met together with a group of stakeholders. We determined our goals. We decided who needed to be involved, and we put together a plan. We then started to implement that plan. And as we were going through, we were assessing on a regular basis to determine how the process was going. And then came back at the end, right, to say, okay, this went well. Here's what we can improve next time. And we're implementing some of those recommendations into this year's approach. So that kind of continuous quality improvement process was experienced through this activity, and it turned out really well for the patients, for the care managers, and for the organization. So thank you so much, Dr. Brodeen.
So Molly, we do have one question in the chat.
Okay.
Says for patients that did not respond to texts. Oh, Dr. Brodeen responded. Yeah, they were put on a phone call list. So the question was, if they did not respond to the text, were follow-up phone calls made? And Dr. Brodeen, did you want to expand on that at all, or?
Sure. Again, it's a great question, Sven. Thank you. And the big list of who we texted is who we would naturally be making phone calls to in a regular way. And so we never took anybody off that list unless they did respond to the Twistle outreach. So they still remained on that list. It just obviously, as we were seeing from the numbers, the Twistle technology enabled us to do a quality improvement activity that did for us in 20 days what our team naturally at their best speed probably takes them about 8 or 9 months to do. So it was really a force multiplier for us. But good question.
And then you have a second question about, have you started texting patients from this year? I think you just mentioned that at the end. So
Yeah, we have been texting patients. We've been using the same approach for diabetes as well as colon cancer screening and as well as breast cancer screening. And then in terms of hypertension, we've been reaching out to patients as of this morning as part of our end of year assessment activities.
okay, thank you for that response. So I'm not seeing any other questions at this time. I don't see anybody with their hand raised. So I would like to go ahead and transition over to Dr. Ferozbi. You're on mute, Dr. Ferozbi.
Thank you, Melanie. It's an honor to join all of you today. My name is Kasha Ferozbi. I'm a medical oncologist, and I am the medical director for cancer services for Adventist Healthcare, and also the managing partner for a private group, Maryland Oncology Hematology, based out of Silver Spring, Maryland. Sorry. So next slide, please. So today, what we're going to do is talk about some of our objectives with respect to this project and how it relates to care transformation. Give a little introduction about our Physician Alliance, our clinically integrated network, which is made up of many different practices throughout the region. And then looking at that, understand the goal and the problem that we had in hand related to trying to find a way to improve in-network referrals amongst all these different providers and practices across our region. We then looked at the methodology and of trying to crack that problem and how we went about implementing a solution and the results that came from that, and then taking that success and looking at some real-life examples around specific clinical algorithms that we developed to streamline referrals. And then also lastly, just some of the things that we're looking ahead in the future around how we can leverage the success we had here to expand the solution to other use cases. Next slide. Next slide, please, again. So Adventist Healthcare Physician Alliance is a large physician-led clinically integrated network of about 2,300 doctors spread across the Maryland, Washington, D.C. region. Our goals, like many organizations' goals, is to improve the quality of care while lowering the cost, and doing so all while improving patient experience. We have a large network of many different types of physicians, over 500 primary care doctors and 600 hospital-based providers, and around 800 specialty care providers, spreading across about 115 practices, covering about 81,000 lives. The good thing is that we've recently had some success and have generated about over $5.5 million of value-based revenue that has gone back to the providers, and has served as an incentive to help stimulate and promote all the practices and physicians to sort of buy in and work harder at some of our core initiatives. One of the things that's unique, and I think that a lot of practices can understand and appreciate, is that we are one clinically integrated network made up of many different practices. And this is a unique situation that creates some opportunities, but also some challenges. Unlike our previous conversation where where MedStar is one large group with one platform and physicians all aligned within that system, our situation is a little bit unique in the sense that we were trying to sort of function as one network made up of many different practices, many different specialties, many different EMRs, many different workflows and processes, which poses unique challenges. Next slide. So our network is made up of 4 medical neighborhoods, we call them, and those 4 neighborhoods are centered around the 4 different hospitals within Adventist Healthcare. So we have our Shady Grove neighborhood, which is up the 270 corridor in Montgomery County. The White Oak neighborhood, which extends to the eastern portion of Montgomery County and into Prince George's County. Our Washington, D.C. hub, which is focused around Howard University Hospital. And then going south into our Fort Washington Hospital neighborhood as well. The goal and the goal of our effort was to really maintain network integrity and improve the quality of care and lowering costs by ensuring that our network functioned more as a system, whereby referrals were maintained within that network. And one of the things is that the network, in many cases, some of the referrals were already in place because of existing relationships, but in many other cases, we built new relationships by promoting practices that were part of the network and developing relationships that otherwise hadn't existed. Next slide. So as we embarked on this situation, this problem of trying to build a network of many different parts, we started by forming a committee, and the committee was our in-network care committee. And that was made up of specialists and primary care doctors and co-chaired by myself as a specialist, as well as Dr. Cohen, who's our primary care doctor lead on this. And we met together and talked through with all the different stakeholders regarding what the issues are, what the obstacles were. We did surveys with all the different doctors to understand what was necessary to promote in-network referrals. We then took the data that existed, the baseline data around the referral metrics and network integrity. We brought in speakers who had done this before across other places throughout the country that could then also communicate the success and the benefits of doing this. We also had our payer partners share with us sort of their goals of promoting this network integrity. And then we after doing that, we sort of worked on trying to come up with a solution to be able to connect all these different parts together. And we agreed upon working with a referral management and communication platform that would then be used as a way of streamlining the referrals amongst all these different players. We focused on 3 specialties that were sort of the high cost specialties: cardiology, orthopedics, and hem-onc. And then we continue to track and monitor success and report back quarterly to all the different practices at our quarterly meetings to promote success and promote sort of continued adherence to our network referral solution. Next slide. So how do we do this? How do we go about doing this? So you know, in the past, I think many of the physicians, we can all relate that there were physician lounges where in hospitals where doctors would communicate and meet with one another, and those relationships would then translate to referrals. But you know, as you know, that those physician lounges are kind of empty these days, and people don't go in as much as they used to. And so we really focused on building trusting relationships. And so we organized social events and where primary care doctors and specialists could meet, centered around those 4 neighborhoods that we talked about, so that we could start to build those relationships that would translate into better referrals. We then created a network and directory that was both physical as well as electronic. That directory was then sent out to all the different practices. And on that HIPAA compliant communication platform, we then prioritized and highlighted and flagged those physicians within specialties that were part of our CIN. So then when there was a referral made, the referral was prioritized to the CIN practices. We sort of worked with our technology partner to sort of reduce the referral friction and to make it easy. We would talk back with go back to our primary care doctors and specialists and say what's working, what's not working. We were fortunate to have a technology partner who could go back and in a very nimble manner adjust and adapt to our recommendations. We then took the data that came from our platform, but also the data that came from the Care First and Care Journey scorecards, and shared that back with our doctors and said, look, referrals are not coming in, but we've really got to prioritize high quality and low cost. And for those doctors who may not realize that they were high quality and high cost, we then went back and sort of showed them what they were doing or where they could potentially improve their scores. Next slide. So this is an example of what the platform looks like. The platform we use is something called Picasso MD. And it has several features. It has a curbside consultation feature where a primary care doctor who may have just a question regarding one of their patients could reach out to one of the specialists in the network and get a curbside consultation. If that curbside consultation required a referral, there was also the ability to turn that curbside into a referral or just to do a referral directly. So there was a rapid referral solution. And then there was also just sort of once the referral was made, there was a way of coordinating care that included closing the loop of all the different members of the care teams between both practices. Next slide. We also worked hard at realizing that not everybody wanted to work through their app to make those referrals. It's not always easy and practical in the middle of a busy clinic day. And so Picasso MD worked with our main EMR that was used by our primary care doctors, which is eClinicalWorks, and was able to build Picasso in a way that could serve as an EMR agnostic solution whereby the referral could go through eClinicalWorks into Picasso MD and then back to the specialist, regardless of whatever the EMR they were using, as long as they were part of our network. Next slide. Once that referral was made, the patient would get a text message saying, you've been referred to such and such doctor, here's the number, here's the contact information. That would make sure that the patient knew what was going on and had an easy way to connect with the practice to get in. Next slide. In addition, we also made sure that there was a closing the loop related to the different stakeholders within the primary care doctor and the specialist office. One of the things I thought was really unique and beneficial, which seems small but really made a big difference, was that oftentimes a primary care doctor might refer a patient to a specialist and then schedule a follow-up a month or so from then, and only to find that the patient hasn't seen the specialist and wonder what happened. Because sometimes that referral can be a big black hole. And so what we did was we actually had primary care doctor included in this communication chain. We had the primary care doctor's referral coordinator included. We had the specialists themselves included, and we had the specialist new patient coordinator included. So all four were in this communication chain. So if there was a hiccup, whereby let's say the new patient coordinator reached out to the patient, but the patient hadn't responded, the primary care doctor would be notified of that, and feel like the specialist was responding to their concern and not ignoring the request, and could also sort of reach out to the patient and say, hey, you got to go see this physician. It's kind of like sort of thinking of like the Domino's pizza delivery, where you can sort of track where your pizza is in the whole chain before it reaches your house. But this was sort of the same with respect to the referral, and knowing exactly how that referral was being navigated through the chain of different spots through the referral process. Next slide. And by doing so, we found some success. And so this looks at some of the success we had with our in-network referrals. So what you see on the left side here is prior to using the solution, we were basically doing about 40-ish% in network referral integrity. Upon initiating this solution, we saw that go up close to 70+%, 75%. In addition to that, when we look at the specialty specifically, we found that orthopedics, which was an area that we were really performing poorly on, upon promoting the different measures that we talked about earlier, including the technologies, we saw that number go up dramatically. Same as well with cardiology. So far, about 13,000 referrals have been sent through this Picasso MD integration platform. Next slide. We also found that the referral outreaches escalated as we continued on this path, and by doing so, the time it took to get seen by a specialist dropped. It became 11 days faster than what we see typically in sort of national as well as regional metrics. And so that was very successful in that regard. Next slide. Once we did this, and once we built this, we said, okay, it's working. The platform's working. The communication's working. All the parts are connected. How do we use this platform, use this solution to focus on specific diseases and specific conditions that can hopefully streamline the process and reduce some redundancy and create some efficiencies, but also reduce some unnecessary visits and unnecessary consultations. And so we had, for example, a direct colonoscopy pathway where we worked with our partnering physicians at one of the large gastrointestinal groups. We created a process map where we could have a primary care doctor refer a patient, have that referral received by the practice, That practice would then ask a series of questions to determine if the patient needed to be seen by the physician prior to the colonoscopy or could be referred directly to and made an appointment directly for a colonoscopy. That process itself reduced a lot of unnecessary visits and streamlined the process through which patients could get their colonoscopies. It was very effective for both primary care doctors as well as the specialists who wanted to make sure that they didn't lose those patients. Same thing applied with the musculoskeletal pathway specifically for lower back pain. We know clinically a lot of patients with lower back pain will ultimately end up getting physical therapy to help address the back pain. And so rather than making referrals to orthopedics who then would then refer to physical therapy, we built a process through which overseen by the orthopedics practices, they could screen questions that specifically determined which patients would benefit directly with a physical therapy referral versus having to be seen by orthopedics first so that they could rule out other potential problems. And that too reduced a lot of unnecessary referrals and reduced the cost for patients. Next slide. Where we are now and looking forward is we're trying to focus on, okay, there are some geographies that may have one specific issue that we want to address. And so we want to look at each medical neighborhood, identify initiatives that might be specific to that neighborhood. We're looking at other disease specialties and saying, okay, well, we've made success with gastroenterology, we made success with low back pain. What are some other areas where we can work on this together, leveraging the success, leveraging the platform and the solution that we have in place to build similar streamlined referral processes. And then lastly, we're also building out dashboards that we're going to then send back to both the primary care doctors to demonstrate how well they're doing with respect to keeping referrals in network, but also to the specialists to understand how quickly they're seeing the patients, how they're responding to those curbside consultations and referral requests, and how they're closing the loop to make sure that the information gets back to the referring doctors. So those are the next steps that we're embarking on as we proceed with this initiative. Next slide. And that's basically where we are. So thank you very much.
Thank you very much. And we are coming close to the end of our time. I don't see any questions at this time in the chat, but people feel free to send me something and I can send it to Dr. Crosby. Go to the next slide, please. So I want to give a big thank you to all of our presenters for sharing how they implement a continuous quality improvement process, and of course to all of the attendees. The recording and slides will be posted on the MHCC website. My contact information is on this slide. And as a reminder, you're going to receive that questionnaire in the next few days. Please fill it out. It is required to receive CMEs or CEUs. And with that, I just want to wish everyone a great weekend and a very happy holiday season. Thank you so much for joining our event today.